Hi, I'm Dr. Arlen Myers. I'm President and CEO of the Society of Physician Entrepreneurs, and welcome to the SoPE Grand Rounds. This conversation today is going to be about healthcare interprofessional practice, and I'm pleased to introduce our guests who are on the panel with me today. Stephen, you want to tell the folks about yourself?
Sure. Hello, everyone. My name is Stephen Ferrara. I'm a family nurse practitioner by background and currently am the president of the American Association of Nurse Practitioners. And I also work at Columbia University School of Nursing as the Associate Dean of AI and professor at the school. So I've had some background in health policy and as a practicing nurse practitioner in primary care. Happy to be here, Arlen. Thank you for having me.
Yeah, thanks for joining us. And how do you want to introduce yourself?
Sure. Good morning, everyone. Thank you for having me here. My name is Hadi Danawi. I'm an epidemiologist by training, and I've been involved in clinical trials and non-profit organizations in the US and globally. And I'm currently the president of the Arab Board for Clinical Research and MINASA Group, which stands for Middle Eastern, North African, and South Asia.
Good. So let's get started with sort of just setting the stage, and that is, what is your understanding of interprofessional practice? Some people call it interprofessional education, but the basic idea is to get healthcare professionals and, in my opinion, non-healthcare professionals who are interested in what we're doing to play nice with each other. So can you kind of amplify on that, Stephen? What's your take on what is interprofessional education slash practice?
Yeah, I think there's a lot of overlap in what we do as different professions. And we know that there are some things that are that we accept as fact. We know that evidence is changing and whatnot, but pharmacology stays constant. Pathophysiology stays pretty constant. There's opportunities for different professions to learn that content at the same time, and not only learn it at the same time, but be able to discuss it in the context of patient care. Because while individuals may take care of patients at different points in in a patient's time, uh, it requires different personnel to care for patients. So it's critically important. I know that IPE, interprofessional education, is baked into some of curriculum where it's not enough in my opinion. I think there's a huge opportunity for a lot more of IPE and it really is the collective learning and environment within this interprofessional grouping that we can learn different insights, different perspectives, all in the hope of being able to provide that patient the best evidence-based care possible.
Patty?
Yeah, I mean, you said it very well. I don't know how I can top that, but interprofessional education (IPE) or, as you said, interprofessional practice (IPP) is just about getting people to work together in collaborative team-based approach, and in a way that we can foster communication, respect, and understanding. I believe across disciplines. I mean, I'm an epidemiologist, and public health in general is an interdisciplinary approach or field. So it kind of overlap with this idea, and the ultimate goal is to actually improve patient outcomes, right? By reducing medical errors, I believe, and to enhance team communications and come up with innovative solutions on how to actually get or have the patients in the like patient-centric solutions or approaches. And really, I mean, the ultimate goal again is to actually have future professionals for real world teamwork and come up with real world evidence. So that's what IPP or IPE is about. For me, at least, where integration and patient-centeredness comes into play.
Mark Allen, are you on with us? Can you hear us?
I am. Oh, I'm
Yeah.
sorry. I
Can you turn your
realized.
You
There we
can put
go.
your, there you go. Can
Yeah, the
you,
cover was on. Hi.
yeah, so we have a cozy little group. So tell me who you are and what you do.
Sure. It's been we haven't talked since last summer, Arlen, but yeah, co-founder of K3, and we're a unique group that really has devoted everything and now into the rural health market. So we've been working with innovation for the last 15 years, and of all things, all kinds of every kind of industry. But we've certainly been dedicated to the healthcare industry for the last 6 or 7 years, and so we predominantly work with all kinds of various healthcare technologies, whether that's digital, whether that's diagnostics. The 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 entire the entire impetus is on the fact that uh, healthcare is such a changing landscape with technology, and we have so many issues that need to be addressed, especially when it comes to accessibility, to lower costs, and the amount of the evolution of technologies is happening so quickly. It's actually pretty exciting when it comes down to things like remote care, the way we have abilities to literally care for people in remote areas in the home, um, has been nothing short of spectacular just in the last several years. And not to mention all the innovations that are taking place
Yeah,
inside of hospitals, thanks to AI, VR, all kinds of things like that.
great.
So we work with a lot of those technology
Yeah.
companies.
Shwal, you want to introduce yourself? You're in the UK. So we have an international group, and that points to, in my view, this is not regional. I mean, we're talking about international, interprofessional education and practice. So, Shwal, you want to tell folks a little bit about yourself?
Sure. Arlen, thank you so much. Good to see you, and thanks for introducing me to the global community. Nice to meet you all. João Bocas, Portuguese national based in UK for the last 24 years to my sins due to the weather. In UK, everybody moans about the weather all the time. It's just part of being in UK. So I became one of these people, yeah. Anyway, it's nice to see you all. So I'm a healthcare entrepreneur. I run a consulting business operating globally, primarily links with the United States and Europe. I was a fitness professional and a sports professional for a number of years. Then I transitioned to corporate wellness and eventually into digital health from 2015. I've been involved in many things. Also, I have a deep expertise in wearable technologies. I was in the middle of doing a post, so I rush in the office to find a quiet place to join the to join the meeting and everything. So anyway, I'm delighted to be here and collaborate with you all, and always learning and evolving as the industry is also evolving. Is a lot happening, is a lot to learn, and is certainly a lot to tackle. But I
Yeah.
appreciate being in here with you all. Thank you.
Sure. So forgive me if I'm pronouncing your name wrong, but Chaim, can you tell us, is that right?
Yeah, it's he am.
Yeah, Hiem. Yeah, good to see you. So tell folks about yourself.
Sure. So I'm currently the director for the Center of Innovation and Care Delivery within an institution at Mass General Brigham. And we have several pillars, but mostly to really actively elicit ideas from the front lines. So not only their pain points, but ideas. And then they come to me in my center for incubation, acceleration, commercialization, et cetera. And so the magic really happens with interdisciplinary professionals, but we're also developing ways to collaborate with industry for co-development, for bringing in startups for piloting, et cetera. So we're trying to really develop the entire ecosystem around innovation.
Great. So so this is a great group. So let's just start with the barriers. So I put up a list, disclosure. I've created this new SOAP house rules where you can't use AI note-taking services on chats like this. It's my pet peeve. Since I run this thing, I can do whatever the hell I want. So I just said, no, don't do that, for all different kinds of reasons. But anyway, I do use large language models every now and then to come up with some ideas. So here's a list, and it's not all inclusive, in the chat of what are the barriers to medical interprofessional education and practice. You can see the list. Now, so let's start, Steve, with Stephen, because, you know, this scope of creep, the scope of practice creep issue, you just can't get away from it. So, Stephen, give us your take on the scope of, so one of the barriers is turf wars, for lack of a better word. I don't know what you want to call that, but it's just people don't play nice with each other. We're not trained that way, et cetera, et cetera. And it's intradisciplinary. I mean, doctors don't play nice with each other. We're people.
Mhm.
So, Stephen, give us your take on, first of all, why is this happening and how important is the issue? As relates to my view of all this is we're all trying to help accomplish the quintuple aim. You know them. So how important is this issue?
I think it's critically important. I think the amount of time, energy, and resources that are spent to counter this notion of any healthcare provider being able to practice at the top of our licenses and training um, is wasted effort when it should be invested into improving patient outcomes and technology and doing all the things we need to do for patient care. Um, for those who aren't familiar, nurse practitioners are licensed, are have the ability to practice in all 50 states, can prescribe medications, et cetera, et cetera. In 27 states, nurse practitioners have full practice authority, which means that there's no requirement to have a contract with a physician in order to practice. In those other states, it is something that without that collaborative agreement, you can't practice anything. You can't do anything. You can't see any patients. And if we're trying to tackle the estimated 70 million people that lack access to healthcare, having this battle is not helping those patients. So, there are states that have always been full practice authority from day one. There have been a number of states in the last handful or so of years that have moved to that model. And the intense is battle. The battle is intense. And again, it shouldn't be that way. The colleagues I work with in primary care are looking for any support that is going to ease the burden of what primary care is today in this country. So it doesn't have to be that way, but to sum it up, I'm going to say it's being able to any profession. We shouldn't be hiring anyone that can only do 60% of their role. They should be able to take full advantage of the role and provide those services to their patients.
Okay, so does this include primary care pharmacists in
It
your
should.
view?
It should. I mean, clinical pharmacy, absolutely. Why don't we have clinical pharmacists, on the front lines with us, managing, complex patient conditions that we need their expertise rather than a phone call that, we're playing phone tag all day or we're playing, email back and forth. We could strengthen this team approach so much more if we bring all of our skills and resources to the table.
Okay. Mark, how does this play out in rural America? I mean, whether it's a CNR, whether it's a nurse anesthesiologist, whether it's a nurse practitioner,
Sure.
whatever. I mean, we all know that there's a so-called crisis in rural medicine. There aren't enough people to take care of the demand. There are wide geographic disparities, not necessarily from a state to a state, from a zip code to an adjacent zip code. So how does this play out, and what's your take on this in rural America?
Well, it's when I came across a stat not long ago, it was very, very shocking when I saw that a person's overall health and care is far more determined by their zip code than their genetic makeup. And coming from I was born and raised in the middle of Missouri, middle of nowhere. I know firsthand what that's like being, an hour away just from primary care. Um, I will say that in rural areas, specifically, not just the whole healthcare sector, but the only way we're going to address this is with innovation. We just can't, hire 4 million new doctors and put them in places. We have to. It's just we're such a sparsely laid out country. But in terms of collaboration. Um, just kind of as a joke, there's definitely ego in every single industry that I've worked in, no matter where you're at. But it seems to be pretty strong within healthcare, within working with doctors and things like that. So I don't know. I didn't come from the healthcare world, so I'm not really sure what the answer might be. But I do fully support the the adoption of collaboration. So as opposed to the sticking to traditions, this is what we do. This is how we the openness I think needs to be more abundant into terms of accepting new ideas, new modalities in terms of providing the care, because that should be the ultimate goal, is to provide the best care possible. In the rural sector specifically, it's just because the workforce shortages are so just they're so crazy. I mean, they're dealing with 80% shortages all across the board in rural America. They're almost, it's like they don't even have time to collaborate, to think. So it's almost we're almost in a position now where it's just like, all right, just adopt it and see what happens, or change and see what happens, as opposed to continue to resist, because we know where that road leads. We keep doing the same things the same way, then you're gonna get the same outcomes. Nothing changes if nothing changes. So I I I know that's easier said than done, but I would strongly support any kind of collaboration. Between urban and rural. Not only that, but between states. One thing we really learned about is that every state seems to do things differently, or every region, maybe more than that. And I, I I wish there was a kind of an easier way to collaborate, to digest information, and to ultimately integrate it into patient care.
Right. So, Zhao and Hadi, give us the international perspective. You guys have been around, well, we've all sort of been to different places around the world, but you come from different places. So give us, Hadi, give us the Middle East.
In the car. Like we agree with that research.
I'm sorry, hi, I need, could you please mute your mic? SG, thank you. Hadi, give us the international perspective, and
Sure.
Joao, you can do the same, whether it's Portugal or England or whatever.
No,
What
yeah,
are you
definitely.
seeing?
Definitely. So I have been involved in, I have a nonprofit organization in the US with chapters in the Middle East and West Africa. One thing that really comes to mind right now is the zipline project that I was actually involved in Ghana, in West Africa, whereby the interprofessional and interdisciplinary, approach that we took, I was part of this, project. And this is where we actually delivered meds and vaccine from the capital city by drones to rural areas in Ghana. This is like a country in West Africa. So, for me, I mean, it's just like, it came to my mind when we were talking about barriers or interdisciplinary IPE approach. So it takes a village, right, to really get to that point. And the barriers is like, financial barriers, like, of course, attitudinal or professional barriers. But when you work together proactively, this is the term that I wanted to actually emphasize, proactively together as a team, to combat, or like, against those challenges and barriers, we were actually able to really deliver a significant amount of medications to rural areas. So I don't know if this really answers your question, but it takes a lot of effort from across different nations and across oceans and across the pond, basically.
Hyam, you live in Boston. You're the epicenter of we would like to think you're the epicenter of healthcare, and probably in some respects you are, but with all due respect, there are other people that do what you do. Uh, so what's the perspective of Boston? I mean, it's an ecosystem hub. It's Mass General. It's the usual stuff. So what's your take on this?
Yeah, I think I'm going to bring it way down to the practicality, because a lot of what my colleagues have said, I don't have to repeat. But it comes to, first of all, we are all trying to solve the same problems, but in silos. So starting within the hospital itself is actually being very deliberate in who you bring to the table to innovate, right? You have to be very deliberate. And once that everyone hears from each other's perspectives, it's always an aha moment that you didn't consider. So starting from there, and now we're trying to reach out to other institutions. In New York, we're working on a project together, but really being deliberate at bringing different perspectives to the table, different institutions, different industry players. I think with COVID, we stood up the COVID Innovation Center, and we invited the entire, just anyone, the community, anyone that wanted to join the teams. And to this day, I've learned more from a retired plumber about, filtration for masks and N95s than I have ever done in my career. So it's really just you don't know where the next good idea is going to come from. So if everybody's there, we could do it. But
So
it's going to take a lot.
Yeah, can you give us an example? You already gave us an example of the COVID thing, but for people that are trying to overcome these barriers more specifically, so let's sort of transition to some solutions. Give us an example of a project either you've worked on or are working on now, and what advice, walk us through the process. How do you do this?
Yeah, so we have we also, by the way, involve patients. So our patients that their kids have been in pediatric intensive care units go home and the resources are not there for them, especially with complicated patients. And so who do I call when my child can't breathe anymore? Where do I get these, their oxygen? Where do they get everything that they need for these complicated patients was not there. So we started to work on this. And then we deliberately invited all other, like Boston Children's Hospital. We invited a New York Children's Hospital. So we're deliberately reaching out to the different institutions around the country, because everybody has their nuances around how they do things. And everybody was working on the same projects. We don't know how to get there. So now we're all coming together and just discussing first of all, what is everybody doing? So if somebody does have a best practice, we can all easily adopt it and move on to the next problem. Or if no one has, then at least we begin to sort of divide and conquer for each particular thing. So that's another example. But people they tell us they've never been invited to the table, so it's a sort of a surprise to them. And when they do, they're really happy to work and cross those boundaries. So although we have all these egos, when everyone is together, they sort of overcome that. And that's just been my experience. So
Yeah. My experience has been, this is like the Ukraine conversation. Yeah, I don't want to get into the middle of what side you're on this, but the point is, if you're gonna sit at the table to try to mutually accomplish some goal, you sort of have, well, you know, sort of, you have to establish trust with the other people, because there are all these barriers and preconceptions and prejudices and whatever. So you have to be able to get people to sit down at the table. First of all, they got to get them to show up. And that's a big hurdle, because everybody's got, a gazillion things to do. This is not a high priority. What's in it for me? How do I get paid? Do I get promoted? How about tenure? What about my grant? There's a million reasons people will give you for not showing up. So you have to find the right people who are willing not just to put a hand up, but who are willing to show up. And more importantly, put up. and in some instances, shut up. So you have to have the right folks. Okay. I call this wake up, suit up, show up, put up, or shut up. You just can't spend time with folks who are going to drive you crazy. So pick the right people and then get them to the table. And it's, I don't care. You have pizza. You don't, all you do is get to know each other. And then gradually, once you develop psychological safety in the group, then you can start talking about stuff and deal back and forth with, no, I don't agree with that, etc. So that's my first step. That's my tip to sort of the first step. How do you get started? So Joao, you want to give us the perspective of the UK and maybe even Portugal?
Yeah, sure. There are many things to consider. One of my frustrations, if you like, 10 years ago, I started going to events and network a lot about our industry, and one of the main questions was like, who owns the data? And at the beginning is a nice conversation, but 10 years later, when you hear the same question about who owns the data, and he's like, I don't have much hair, but I just want to pull my hair out when I hear this stuff. So anyway, one of the things that I think finally we are perhaps getting somewhere, in Europe, the EU create a new European like AI Act, and I think now things started to kind of consolidate. The progress is still very slow, but things are actually starting to get into place with the data, with the regulation, with the AI, and uh, a few years ago, as you well know, was the GDPR, and now we have the AI new act, and they try to merge them together for best practices. So all I want to say is that perhaps with all these learnings and all these frustrations, the industry is actually taking some kind of direction, and things are improving. Even though I have a lot of frustration thinking, oh, we in the same spot we were 10 years ago, because, for example, the national health system in UK is a little bit messed up, as all the systems are around the world. There is no money, the same challenges. The delivery of healthcare is very fragmented, and shortage of staff. All these challenges are actually global. It's not just the UK, but things are actually progressing. And I feel that the industry is much more open. It's got more people, more clever people at the table, if you like, and we are here to talk about common challenges globally. But also, I have this. It's more a personal thing that I would like things to happen a bit faster, and healthcare is very different than any other industry, even though I only have perhaps experience in one or two industries. I've been in healthcare for a long time. It's my industry. I don't know about banking or fintech. I don't know about that. But I have the impression that, of course, the challenge is greater. It's probably the most complex industry. And I talk healthcare, we talk about biotech or even pharma life sciences in general, yeah. But it's the industry that we like. It's the industry that we love. We want to make a difference. We want to make impact. We want to collaborate with others. But to resume my line of thought is, I think we are starting to have some leeway and getting somewhere, making progress. And I feel that as an industry, as digital health, I would like to call the industry as digital health because it replaces my old thinking of the healthcare traditional industry. We moving into, of course,
Okay,
technology.
so from the perspective of drug discovery, development, med tech, commercialization, basically upstream. So we're talking about interprofessional collaboration at various levels of the value chain. One is creating the product, whether it's drugs, devices, whatever, that requires interprofessional cooperation. It could be clinical trials, it could be all the stuff you have to do. And then there's the care delivery part, which is what we're talking about. Like, okay, people like us or some of us develop these things. We're trying to get them to market. We're trying to get them to patients. And if we're lucky, we do. But now we got to figure out a way to get people to use them responsibly, whether it's AI or drugs or whatever. And this comment about about startups not in, a frequent refrain is, why don't startups, and they typically point to the EMR, which I think is becoming sort of a tired model, but the point is, why didn't they get doctors involved early in the game so we don't wind up with trash? And several people are, we keep saying the same thing over and over again. What, you're developing AI products, you didn't get health professionals involved, then you dump it on us, and now it's trash, and we have to deal with the consequences. Same thing with EMR, same thing with robots, same thing with, just the list is endless. So from a product development and entrepreneurial standpoint, and I don't care whether you're a nurse practitioner or an MD or a technologist or an AI expert or a behavioral health person or a public health official, how to give me an example. So let me just ask a different question. What is the one thing you would recommend that you have seen that is successful that get people to collaborate, interprofessional collaboration? What is the single biggest barrier you see, and how have you overcome it? Anybody?
I mean, I don't know if I have all the answers, but one of the things I did was just actually reach out to industry and said to them, look, before you spend all this money on commercialization and stuff, let us test it for you. Let us give you feedback, which went over well with a couple of industry players because now we're collaborating. But now they've come back and said, hey, you know what, you're right. We have an idea, and we think this is a pain point, but can we now run it by all your clinicians and stuff? So I mean, I'm starting small, but it's been successful. Not,
Okay.
so yeah.
So yeah, so Hadi, tell us about, how do you get, or how are you getting, in this case, drug discovery development medtech companies to include, engage, recruit clinical trial subjects outside of the United States?
Well, this is like a long discussion, but I mean,
Give us the headline.
yeah. So I can talk and talk.
Yeah,
but
give me the Cliff Notes. Right.
yeah, but
Right.
briefly, you really have to get those stakeholders involved and the designs, stage or phase. Like like in clinical trials, for example, you cannot really go out and just like say, okay, we have a study right now, we're going to India to recruit, without getting those ad groups and SMOs and CROs or whatever, or patients, physicians involved in the clinical trial design at the start. So we have to really incorporate this. It's a mindset whereby pharma should really have to include all those stakeholders, like, in the study design or the initial planning phases. That's the biggie for me, because I mean, cultural competence, talking about cultural competence, talking about like, barriers in specific, like localized, geographic locations. I mean, these were not actually been taken into consideration so far. And we're moving towards where we want to actually include that into the planning phase. And the other thing is that, pharma is not paying for, like, again, specifically when we're talking about clinical trials, pharma is not paying for or sponsoring community outreach programs. So, I mean, this is really a must, where we can actually get pharma to agree, whether in the negotiation phases or early on, or I mean, even we were actually having some discussions with FDA earlier, last year, or at the end of last year, whereby we want to actually impose, friendly, amicably impose that to pharma, whereby you cannot go into any state and actually have clinical trials awarded to, like, PIs or sites without having to actually incorporate a line in the budget whereby you actually sponsor community outreach programs. So there are so many things that we're actually working on, and I'm trying to be brief, and I hope I answered. Okay.
Yeah, good. Thanks. Stephen, do you have anything to add? What are you doing at Columbia?
I mean, I think the advantage we have at an large academic medical center is that there's not a lot of the emphasis is on patient care, right? Delivering excellent patient care. And I think there's a realization that we need everybody that can contribute to contribute. I think we get a little bit wrapped up. We don't all understand everybody's role, and I think that's part of the like first step in this process. Is recognizing what folks can do and bring to the table to be able to again practice at the top. So, I've been fortunate to work with colleagues who recognize the contributions of everyone and realize that they can't do the work that they can do if it's not at everyone operating to their most capacity. So, but I think that's the exception. I don't think that's necessarily the norm. And I think just getting a recognition that we're different. We have different training. We have different, sort of frameworks that we come from. But at the end of the day, our mission is common. Our goals are common, and again, we should be able to do that. And I think in this, I've been in AI for a relatively brief time, since last year. So far, I've seen AI be that thing that is bringing everybody together. And I think there's a lot more work to do. I've been exposed to some tech companies that are coming out with solutions specifically for nurses, and I asked them, where are the nurses on your leadership team? And they don't have any. So I think there's opportunities there for everyone. But the recognition that, we need everyone.
So this speaks to the challenge, and it's in the list that I put up, which is lack of role clarity. People just don't know what they're supposed to do, and are they willing and able to do it? There's just some folks that simply don't know how to do this, or they're not willing to do it if they did. And what are the expectations? What are the timelines? What are the deliverables? How are we going to hold you accountable? How are we going to manage? Who is going to manage and lead the project? So there are multiple layers of all this, but to me, the big picture is clarify the expectations. It's a team effort. Who's responsible for what? And if you look at, multiple things about scaling enterprises, it really has to do with people, strategy, execution, and money. And you have to keep people on track. You have to have like almost weekly meetings. I mean, I'm not talking about daily handoffs from nurses to the ICU. I'm talking about these projects and these things where you're trying to accomplish a specific goal. The second thing I would say is that, and I keep referring back to the 70-20-10 rule, people learn things. It's said, I don't necessarily agree with the whole thing, but there's this hypothesis and theory in adult learning theory that 70% of what we learn is derived from experience. 20% is derived from people, the people that you work with and what you learn, whether it's good or bad, the hidden curriculum. And 10% is what you learned in school. So the bottom line is, don't let school get in the way of your education. Now, if you're going to think big and start small, again, my opinion, the best way to do this, and I referred to this before, is to get people together in the same room. Now, these Zoom calls are fine, and this is a very, very small step that and thank you for participating, just so we get to know each other. Can we talk to each other at the end of this call? Put your LinkedIn thing in. Hey, by the way, I want to talk to you out offline, etc. But I believe that the social impact and building trust and social equity is about 10 to 15 times more effective face-to-face than on a Zoom call. So you have to get people together in the same room. And however long it takes to get them in the same room, you do it over and over and over. and like these things? Or so Hadi, tell people about the conference that you're organizing to get people in the same room.
I mean,
So,
again,
oh,
can you
sorry.
hear me? Okay. So, yeah, thank you, Arlen. So, again, Zoom is wonderful, and all virtual meetings are wonderful. But what I'm trying to do is to really get people together in a summit whereby we can discuss the best practices and how we can demystify the clinical journey, a clinical trial journey for healthcare professionals, especially probably for naive private practice physicians, on how we can train them, certify them, and get them research ready, so that we can actually put them or like place them in a big proprietary platform which houses 2.5 million global users, and highlight them to sponsors whereby we can actually trickle or award them trials. So I'm hosting a summit in Houston on April 19, 2025 at the United Way of Greater Houston. And again, the audience is healthcare professionals, naive private practice physicians, and more specifically, so I'm targeting MINASA communities. MINASA stands for Middle Eastern, North African, and South Asians. And the reason why we're doing that, because they're still underrepresented in clinical trials. FDA is wanting subgroup analysis for these, underrepresented categories. And because just recently, 6 months ago, Congress has signed off on Directive 15, which states that MENA, the Middle Eastern and North African, are now a separate demographic unique category under the U.S. Census, and this will be reflected under the U.S. Census 2030. And we were actually very proactively involved with the FDA with the Diversity Action Plan, which I know right now is on hold, but we're actually having a lot of discussions with FDA and with the new administration to reinstate the DAP under the FDA, so that we can actually have subgroup analysis for these underrepresented populations. So this is what we're doing. We wanted to really spread the word and highlight the importance of getting those non-traditional people of color. We're not talking about Hispanics or African Americans. We're talking about the non-traditional people of color, the Middle Eastern, North Africans, and South Asians, because these people are genetically different than whites. Because MENA were lumped under whites in the past for the several few decades, or I don't know how long. And South Asians have been lumped, or they are still lumped under the Asian, but they're genetically different than just Asians in general. And MENA are different than just genetically different. They have a different genetic makeup than the Caucasians or whites. So this is what we're doing for the summit.
Great, thanks for that. So Hyam, you had some comments you wanted to make? You're on mute.
I didn't know if you wanted me to bring up what we're trying to do at HIMSS as well.
Yes.
Yeah. So Dr. Myers is running an Emerge program 2 days before our event, and we're running a techathon. So we're really putting out a call for all interdisciplinary professionals to get around the table and try to solve some of the problems that arise during the Emerge program at HIMSS. We'll see how it goes. We're limiting it to 125 attendees, and we've already received 93 registrations. So we'll see how that goes, and this could be a beginning.
Yeah, thanks for that. So just to clarify, I'm not running it.
Oh, you're not running it? Okay.
No, I'm participating in it. And just to clarify, you're all familiar with HIMSS, but HIMSS was getting pushback that it's too big, it's too anchor tenant focused, it's too big everybody just selling stuff to big everybody. So the idea was, let's try to interpose into the conference a conference within a conference, which is what this is. So HIMSS is a 4-day conference, but 2 half days, Tuesday and Wednesday of the conference, is totally dedicated to the needs of early seed stage companies from the perspective of investors, entrepreneurs, interesting retail, CVS, Walmart, retail primary care delivery, mostly, One Medical, Prime, all that stuff, and healthcare organizations. So the people who are going to be, and it's sort of a reverse pitch. In other words, the people that represent those industries or subsegments of our industry are going to be talking about the problems that they want solved. And then the entrepreneurs are giving them a best shot instead of vice versa, instead of selling a solution, looking for a problem. So that's the way this is going to play out, and we'll see how it goes. And as Hiam said, it's a new thing. We're trying new stuff. I'm involved with another group of about 8 or 10 consultants, advisors. Give us your 2 cents. How do you think this thing should play out? And we were just involved in giving ideas to the guy who is actually creating, named John Tierney, who is actually creating the event. That's his job. He is professional meeting planner, organizer. So anyway, that's the drill. So but the point of this conversation is it starts with getting people to exchange ideas and get to know each other. And there are multiple places where you can do this. Unfortunately, the people, our colleagues, have very, very limited networks, and they just don't see the motivation or the reason for them to do this, to go to a meetup, to go to a meeting, and you don't have to spend a lot of money to do this. I mean, in every major metropolitan area, there's stuff happening all down the block. So it's just a question of motivation and wanting to do this. So Stephen, to that point, what is the appetite? And I'm assuming, Hadi, that when you say naive doctors, you mean health professionals, nurse practitioners, PAs, doctors, DOs, MDs, MBBS, whatever, just to make that clear in the spirit of this conversation. So, Stephen, what is the appetite for nurse practitioners or the reality on the ground to participate in or lead or co-PI in a clinical trial?
I think the appetite is definitely there. The challenges I see is that certain institutions may not allow NPs to be PIs on certain projects. So there are some institutional barriers there, but I very much believe that uh, we'd love to be able to participate in these, other avenues, again, with the intention of improving patient outcomes, improving healthcare delivery, and being able to, provide the best possible care that we can. So the desires there, the institutional barriers and some of the traditional barriers exist, but they need to be changed. And that's a process that unfortunately you can't snap your fingers and have it done. There's a lot of politics in institutional bylaws and whatnot. But all it takes is a motivated group of people to move it forward. And I think that's it. You have to have the conversations and you have to have a common goal.
Mark, do you have any comments?
I do. Specifically, you're talking about the conferences. I think that the way a lot of these conferences have been built, have been choreographed over the years has been a real disservice to the industry, namely because of what was just said there. You have a lot of industry trying to persuade someone that they need something, as opposed to listening to, what are your problems? And that actually kind of drove me nuts enough last year where I'm working with several states, Maryland specifically. We're putting on a conference in May. It's a Mid-Atlantic Innovation Symposium, and we specifically made it where number one, it's going to be small, so none of this HIM stuff, but it's going to be smaller, about 150 people. But there's a questionnaire that goes out first, to the practitioners. What are the problems you're seeing? How can this be better? And then with that in there, now we can have the industry kind of give examples or collaborate with them based upon the problems that they're getting firsthand from those people. And so we're very excited about that. I thought it was a very simple solution, but everyone's like, "Oh man, that seems perfect." So I really hope conferences can start being shaped more towards the participation of the attendees as opposed to just who are the sponsors and things like that. So that I think is key for this, for collaboration, is getting down with them and really listening to the problems they're seeing, and then shaping that innovation, those solutions to fit those problems.
So tell us where this conference is, just so if people want to go, they can go.
Sure, it's gonna be in Bethesda, so it's called the Mid-Atlantic Innovation Symposium. Along with us and a couple others, it's with the Maryland Rural Health Association. So I'll certainly try to find a link to it. We
Yeah.
just kind of finished it up last month, so we're
Well,
I'll make sure to post it.
put your email or something in the chat so people on
Sure.
this call, if they want to learn more or attend or whatever, can go.
Okay.
Yeah, I think that's great, Mark. And then the one sector you can't forget is the payers, right? Doesn't matter how much we innovate, but if unwilling to pay or
Yeah.
they cause us a lot of burden.
Right. And there's a second group, which are the patients. Now, you've mentioned that more and more people are waking up to the fact that, gee, maybe we ought to talk to the patients. And so, and I've sort of riffed on this. You know, I call them patient entrepreneurs because they're the ones that come up with these ideas. Like they drive, you know, they have this horrible experience. They're banging on a table. God damn it, why don't you do something to fix this? If I see another clipboard in an examining room, I'm going to shoot myself. That kind of thing. So tell us your experience. You mentioned that you are engaging patients. So give us the headline about what have you learned. Obviously, you're learning stuff from the patient, but in terms of the behavior and the system and just getting them engaged, what have you learned?
Well, I think many systems have the patient advocacy role, but most of the time it's just really us, the health providers, just going into them and giving them updates. So we've never really involved them in asking them, what are your pain points? And that's exactly what we did. We said, what are your pain points and what are your ideas for solution? So we wanted to hear from them. And then we partnered them with clinical people so that they were both developing the ideas further and very, very highly engaged and want to help. They're there because they want to help. And so, you know, we're developing all sorts of platforms and things now with patients. And what's, for those of us that are providers, I think over the years, what we've learned is there's a lot of tension between providers and patients. And what this process helped was the patients learned how complicated medicine is and the health systems. And we learned a lot more from listening to the patients. So I think it's strengthening that relationship again, which I think is really important. But that's what we're learning.
All right. So we're talking about patient-centered problem solving.
Yeah.
Actually, patient-centered problem seeking.
Seeking.
And that's another point. So
yeah.
we're so consumed with problem solving, we're not listening to people to understand problem seeking, pain points, all the stuff we're all talking about.
Yep.
And to that point then, so Hadi, are you inviting patients to your meeting?
That's
or Mark, are you inviting patients to your meeting?
We haven't, but that's a good idea. It's a really good idea.
Yeah, you should. You should just reach out and say for free.
Yeah.
And have like a little focus group or a group or something just to get them in the room.
That's
and let them mingle and talk to people, and it's free. Not only that, we're going to feed you. So I would, you know, if you have to do that if you want to get medical. And that's another point. Medical students, residents, early trainees, early innovators, adopters. We're not talking about the late, you know, the laggards. Forget about. I mean, people like, you know, just forget it. Just wait for them to die. Go for the people that are, you know, the early adopters and the innovators to cross the chasm and engage those folks. And I will tell you, and I think most of us have had this experience in professional education, these folks are dying to get in the game. We're just not giving them the opportunity to do it for a number of reasons, not the least of which is because we teach to the test and forget the rest. The only thing they're interested in is passing part one, passing part two, getting a residency, and then going out and getting their first job. And when we start talking about, we want you engaged in AI entrepreneurship, their eyes glaze over. So we have to sort of rethink. I could just chapter and verse about this. but we need to rethink, and obviously my mission in life is to change medical education and how we do things. This group is part of that. So that's what I would say. So great. So this has been a great conversation. I hope we've derived some sort of action items instead of just whining about how awful everything is. So let's give us some final thoughts. So Stephen, final thought.
I thank you for inviting me to this forum. I think this is a start of, again, deepening our networks, building out our networks, having conversations with different professions and different folks. And I am hopeful. I am hopeful for the future. We know there's a lot of chaos around healthcare right now, particularly. But I think I think therein lies opportunity. So I will remain hopeful, and happy to connect with people, and hopefully I can be able to join some of the conferences. And I had the ability recently, in the fall of last year, to attend conferences outside of my own, like, nurse practitioner, and there was a lot of energy, and there was a lot of excitement. The next step is channeling that into something that produces something positive. But it was nice. So get outside of your comfort zone, go interprofessional, and you will find the folks who wanna collaborate with you.
Yeah. I tell people sick care can't be fixed from inside. No
No.
industry can be fixed from inside. And the last place in the world you're going to find medical innovation is at a medical meeting.
Yeah.
So you have to sort of get out of the box or get out of the office, whatever trite phrase you want to use.
For
Hadi,
sure.
final thought.
Communication, be proactive, and just reach out. That's what I'm trying to do these days. I mean, I've always been proactively involved in many initiatives. Clear communications, and just reach out to people. Just ask.
Okay. Joao?
Yeah, sure. Without going back, but I loved Mark's insight about the conferences, and I don't want to criticize the industry or the health systems or anything like that. But the conferences, unfortunately, are very, very focused on the commercial side. One of the big conferences, they even charge for a ticket, and then they charge extra for matchmaking with people, which is the wrong thing to do. And you are here, Alan, you organize this back of your own time. And I personally, I'm very proud to work extremely hard for many years, and I have a big network, and I connect people for free of charge. And you do the same, Alan, I know that. And recently I organized a new initiative that I invested a lot of money and effort, health tech leaders dinners around the world. And people are just show so much interest. No fees, no consulting fee, no memberships, no high ticket prices. Pay for your dinner, 30, 40 bucks, and the great people on the table.
Yeah.
I had so much uptake, and people start asking me, can you do one in Singapore? Can you do one in Canada? Can you do one in, hang on a second, I still have but anyway, there is a great need for exactly what we are doing.
Yeah. SoPE had at the JP Morgan conference, SoPE had we created a curated dinner. We invited 20 people to a dinner, not at when the JP Morgan conference was going on, not part of it. And people said that was the best part of the conference. They could actually sit down and talk to somebody,
talk to people,
let alone the free food and the wine. And we paid for it. Yeah.
At the conferences, people are also trying to sell their stuff, and I have this technology, I have this solution, and
we kind of made it a no sale zone. We should just get to know each other. Right. Mark, final comment. We're running out of time.
Sure. I'll say this real quick that there's definitely a lot to be worried about in looking at healthcare overall, but I actually am quite optimistic when I see all these innovations coming through, and not just better tools for the outcome of the patient, but also for the provider. Using AI and pharmacogenetics. I mean, you're getting these new tools now that can just completely alleviate administrative burden, get down to the patient's genetic level, get it right to the specific care, just makes your job a lot easier. So I'm actually very, very optimistic as to where the industry is going to go.
Great. Yeah.
Yeah, me too. Let's just start somewhere and just keep it going.
All right. So you put up a thing about your meeting. You want to give us 15 seconds on the meeting and
Oh,
are
when
you
you,
expecting us all to attend?
if you'd like, I just pitched to Harvard Medical School that we should start teaching med students and residents and nursing students all about design thinking and
Right.
really how to innovate in healthcare. And so they agreed to do it. So we're just doing a 2-day course. So
Good. All right.
October 3rd and 4th. So I just want you to know.
Well, if you want me to help you, we can give you some ideas. I'm happy to do it. Well, thanks a lot for
Okay,
your
great.
insights. It's been a lot of fun, good ideas. Hopefully we'll actually get something done. And I hope to see you on the trail. Thanks a lot.
Thank you so much. Nice to meet you all.
Thank
Thank
you.
you, Arlen.
Right.